It's my pleasure to speak with you today. I'll show some slides, and obviously I tried to leave a fair amount of time too, just to talk, answer questions, see if I can help you. I will say that I cannot see the chat at the same time I'm presenting, but I'll look at it at the end. And as Nancy said, I think they wanted the format to be one of presentation and then chat. If you know me, you know I like to chat.
We can't hear anymore. I can't hear you now.
Can you hear me now? We're good?
Yes.
Sorry about that. I think she muted everybody and that included me. Sorry about that. So what I was saying is this has been an interest for a long time of mine clinically. I've noticed that women and men, in my opinion, often seem to express inclusion body myositis differently at times, and I'll show you why. My colleagues utilizing our cohort of patients have shown certainly differences with regard to women, and you can tell me if you've seen it yourself. So let's see, hold on. I told you this was the hardest part. There we are. These are just disclosures to tell you that I do a lot of things and I don't necessarily think for this audience that's a big issue. But all right, the one other thing I'm going to do is move me off the screen. Okay, so just a very brief overview. If there are any of you who are very new, so I assume that some of you have been doing this a long time and living with this illness for years, and I would assume that some of you are just joining. And so for those of you who haven't had the wonderful opportunity to either attend in person or virtually through the Myositis Association, where I have been a proud board member years ago, and I've just rejoined the board. So again, thank you to TMA. So IBM is classified as one of the what we call idiopathic inflammatory myopathies. So in the medical literature, that abbreviation is IIM. And that is among many diagnoses. When I went to medical school, I heard about dermatomyositis and polymyositis. And polymyositis, while we still talk about it, to be honest, is really falling out of favor. I suspect by the time I retire, which isn't too far off, that will be out of the nomenclature of the medical literature, because I really think there are very few people who are classified as that disease. And I'll tell you why. Many of them have another diagnosis, and many of you, I am sure, on this call were told you had polymyositis before you were told you have IBM. That may be because it was misdiagnosed, or it may be something that I'm very interested in. Some of you, my own patients, did look like they had typical what we would call polymyositis, but then morphed into IBM over years, where you were initially perhaps responsive to steroids or other immune suppressants, and that may have changed over time. Perhaps you didn't have hand involvement in the beginning and then you did later. So I'll park that diagnosis and say, I don't know that it's a great one, but it may or may not be a continuum for inclusion body myositis, where you present to the doctor with one and IBM is your fate down the line, or you were misdiagnosed from the moment you hit the door of the clinician's office. Dermatomyositis, antisynthetase syndrome, immune-mediated necrotizomyopathy, these are very large words that even most practicing physicians who are not a neurologist or a rheumatologist really don't know. So we have become so careful in precision medicine, trying to be precise about what we call these diseases, not because it's an academic exercise, but because we don't want to lump too many people into the wrong category, offering therapy to someone who might not benefit or not offering it to someone who would. And then there's overlapping myositis, and that can be with Sjogren's syndrome, with scleroderma, with rheumatoid arthritis, and in rare cases with lupus. So there are several key clinical features, this group could probably tell me more than I can tell you, that can aid us as clinicians in differentiating inclusion body myositis from the other myopathies on this screen. I'll tell you about them in a minute, but before I do that, I will mention that you know this. The diagnostic journey is complicated. There is a delay in diagnosis for most people from the onset of symptoms to diagnosis. I'll show you how that differs in our own cohort. So it's said to be relatively rare. I think that if you talk to enough people, it's probably underdiagnosed. We are seeing more cases of it as it's more recognized, as people, fortunately, who are willing to lend their name, who have fame, who tell people about the symptoms and what they look like. That has helped with, for sure, with recognition. Why is there a delay in diagnosis? Well, people attribute it to normal aging. Why? Most people, although we're seeing them a little younger and younger, most people are over 50 when they get the diagnosis. Many of you may say, look, I'm on this call today and I wasn't 50. We're seeing a shift toward the 40s. You technically have to be over the age of 30 for this diagnosis. I can't recall seeing anybody in the recent past under the age of 30, but I've seen my fair share of both women and men, unfortunately, in their 40s that have this disease. But those of us who are a little older, we're a little creakier, things hurt a little more, we just say, gee, it's a little harder to get off that chair. Or maybe I didn't notice, but I can't really grip the way I used to. And so people give every excuse possible that they're aging and they don't really recognize it initially. Doctors certainly don't recognize it. You can't diagnose what you don't know. And so we need more outreach to educate family physicians, internists, people who you interface with, gynecologists, all the people who will see you in a different setting that would need to know about this. And so I think that there needs to be a campaign for earlier recognition, especially, and toward the end of my talk, I'll talk a little bit about this. If we are fortunate enough, and I believe we will be, to get a treatment, obviously most of the time earlier is better for those things. So early recognition is important. Also, even the therapies that we have today, which arguably are minimal, they do help with earlier recognition. So early symptoms may be subtle. They can be mimics of other disease. Some people may have been told they might have ALS, heaven forbid, or something else. So how do we differentiate the clinical features of inclusion body myositis versus those of others? Well, you see, this is sort of a nice little schematic of more suspicion versus less suspicion. When do I suspect this? It's insidious. This is not, I was fine Tuesday, I woke up on the following Saturday and I had problems. It just doesn't happen that way. It's greater than 6 months, and many people will tell me it was greater than years. They suddenly couldn't keep up with their children on a walk. Something seemed different, and then they fall. So that's usually what brings somebody to attention, is often it's the first fall. Asymmetric weakness for sure. The other myopathies tend to be remarkably symmetric, so much so that if we image your muscles, you can almost lay one muscle on the other. It looks as if your immune system tagged your muscles in a perfect mirror image of each other, for example, in your thighs or your upper arms. IBM is different. Many of you will tell me my right upper arm is stronger than my left, but my left lower leg is stronger than my right leg. So there's a crosstalk there that's a little unusual. It's proximal and distal. What does that mean? It means that it's at the shoulder girdle and the hips, but also in the finger flexors and the toes or the ankles, where often the other myopathies really only affect what would be called proximal, closer to the trunk. Distal is further than our trunk. Finger flexor weakness, we'll talk about that. Finger and wrist flexor weakness, which is greater than intensity or weakness than the deltoid muscles, which are those of our shoulders. Knee extensor weakness greater than hip flexor. This is a wonderful quick test for a physician, because in general, most of the inflammatory myopathies, like dermatomyositis, like the antisynthetase syndrome, or the others that I had on that slide, show hip flexor weakness, the inability to sort of march, right, with that leg, pull it up off the examining table, versus being able to extend our knee. In inclusion body myositis, those knee extensors, which are our quadriceps, are weaker than our hip flexors, which actually comes from the back muscle called the iliopsoas muscle. And CK, the muscle enzyme, is generally low, 10 times the upper limit of normal. That's under 2,000 on average. But many of you on the screen, even my own patients who have perplexed me for years, sometimes have very high CKs. And I think that's another discussion of how high our muscle enzymes are. Does that tell us something about the type of IBM you have? I believe in the near future, we will have different subtypes of IBM. I think we're getting there. And usually this does not respond to immunosuppression. So there is data that shows that steroids actually make inclusion body myositis worse. There could be increasing mortality with steroids. That may be a confounding study and showing that people that get steroids are just sicker, and we try everything because as doctors, we feel we owe you something. So when you come through our door, we like to give you therapy. So what decreases my suspicion that you have inclusion body myositis? Pain. Now, people do have pain, but this is generally a more painless illness than many of the other myopathies, at least so I'm told. But one thing I've learned in life is that doctors have all kinds of ideas about how these diseases affect their patients. And then their patients tell them, actually not so much. So I always like to ask patients, do you feel pain? I will say, I think it's in the minority of patients. And in my experience, that pain seems to come from the fact that you have to compensate with other muscles, pulling on other muscles to do the work of the muscles that are weaker. So there may be a compensatory pain mechanism there, but primary muscle pain coming from the muscle cell itself, it doesn't seem that is as common. If you're more proximally weak than distally weak, we talked about that. If you have anything like a weird rash, which is part of dermatomyositis, interstitial lung disease means your lungs are involved. And thankfully in IBM, the lungs don't get involved that way. You can have respiratory muscle involvement causing some shortness of breath, especially towards the end of the disease. But in general, lungs are spared. Raynaud's phenomenon is when the hands turn blue or white in the cold or with stress. Again, that doesn't tend to be a feature of IBM. And then myocarditis or arthritis, so inflammation of the heart or joints. Again, inflammatory arthritis, no. Garden variety osteoarthritis, you, me, and everybody on the screen for sure, but not the inflammatory kind. And then very high levels of muscle enzymes, as we talked about. Okay, and then you see the schematic. I should have a woman schematic. It's always a guy because we think about men, older white men have this disease, but that's why you're here to tell you that there's plenty of women. But this is sort of the main muscles that are affected over there. Okay. So again, this is just how does a doctor think about the possibility of IBM? We've already discussed a lot of this, but it's this insidious onset knee buckling. You have a foot drop or falls. Your grip strength is reduced, and you might have dysphagia, which I'll show you the numbers for that, which is inability or difficulty swallowing. When I inspect your muscles, I'm going to look for atrophy of your quadriceps, and you could look down at your own thighs and say, yes, I've seen that. Scalloping, which means to me, if I'm looking at my forearm, the way that your forearm is generally structured is that it's sort of convex out. And as inclusion body myositis progresses, you see a scoop or a scallop of that forearm looking down at your own forearms instead of seeing an outward outline, right, where it's convex, it's more concave. Palpate, so that means to feel, and that's, again, quadricep weakness. And then the strength, where we talked about this before, that it's the distal strength that is more affected than the proximal strength. And it's difficult to bend at your distal interphalangeal muscle or joint, which is called the DIP joint. What does that mean? When doctors are taught to look at somebody's grip strength, they often say, can you grip my finger? Can you hold on? I'm a rheumatologist by training, but I have a joint appointment in neurology, and it's because I've spent a lot of time looking at neuromuscular diseases. And for those of you looking at your own fingers, what you'll see the difference between making a fist, which you can cheat. I've talked about this a lot, right? We can sort of, we're hardy people. We'll cheat and use the other muscles in our hands, which are called the intrinsics. Sometimes doctors miss that. You can, some people, especially earlier in the disease, have a decent grip. What gets compromised is the ability to fold to the first crease of your palm. That's called the first palmar crease, and that is restricted. So that's how I start looking for grip strength inability. And then if you see me in the office or any of my colleagues here at the Myositis Center at Johns Hopkins, you'll see that we try to pry off your fingers, either from our own finger or on their own, right? So that is a phenomenally helpful earlier symptom, but not all women seem to get the finger flexor weakness. We'll talk about that. Hyperextension of the gait and difficulty walking on your toes or heels. So often we'll have you walk and see, can we bring out some of this earlier than even you're noticing it? And then the lab values we talked about. There are myositis specific antibodies, which means proteins made to your own self proteins. There's an antibody response, and there's something called a CN1A or an NT5C1A. Many people say, what does that mean? We don't really know. So some studies say that if you have that antibody, you have more severe illness. Our studies and others say we're not so sure. It's equivocal. We're not sure what that antibody means, but sometimes if I'm really trying to decide, is this early IBM or is this something else? And I see that antibody, it is helpful. Do we see that antibody in normal controls? We do, rarely, but healthy people can have that antibody. This just came up this week. There was a 90-year-old man who came for some other reason to one of my colleagues' office. He has no obvious IBM physiology at all on exam, and somebody sent this antibody that is positive, and they're trying to debunk it and say, gee, is this something who's going to develop IBM? I don't know. At 90, I will tell you, doesn't have IBM today, and I think it's unlikely. So sometimes it does exist in the general population, but that's rare. And we also see it in Sjogren's syndrome and in dermatomyositis. So it's not specific for IBM, and if you don't have that antibody, it doesn't mean you don't have IBM, okay? I'm going to skip this in the interest of time. It just really is a summary of what I just said. Again, I feel like I need more women on my slide, but these are all of the things that I just showed you. So this is this scooping of the forearm, quadricep weakness, and this finger flexor weakness. Okay. A phenotype is the way that doctors think about what people look like. So how do you present to me, to my eye? So the way I think about inclusion body myositis is not one size fits all. Early onset, versus late onset, right? I have people that present to me in the office at 85. They've never had symptoms before their early to mid 80s. And then there are people in their 40s. What does that mean? Why? We don't know. Men versus women, that's why you're here. Rapid progressors versus slow progressors. We all know people, and what frustrates, I think, some is that if you're in enough support groups, some people seem to have been progressing maybe over decades. They're not using many assisted devices. Maybe they have a cane, but are not in a wheelchair. I've had people also go to a wheelchair within 2 years. That's very, very uncommon, but so much so that I thought the disease was wrong. So there is a wide range of how people progress. In general, inclusion body myositis is a relatively slowly progressive disease, but there are a small subset of people that progress rapidly and we don't know why. So look, this is your medical school for the morning. On the left is what a normal muscle looks like. When I look under the microscope, I'm going to see in cross-section, nice pink, this is stained, something called an H&E stain. It's a nice pink muscle. In cross-section, all of those muscle cells look about the same size, shape. That's a normal looking muscle. The little purple cells that you see in there are the nuclei of the muscle cells, and they're in the periphery. On the right, you certainly see purple cells there. So those are inflammatory cells. Those are lymphocytes. And those are, those surround but don't invade normal fibers. And you can see there's small cells, big cells. So the myocytes, the muscle cells, are all different size and shapes. And then inside the cell, you see some little purple cells there. When the muscle is injured, the nuclei around the periphery of the muscle cell come inside it. So this is something that doctors call a myopathic biopsy. And what I'm going to tell you is that if I did not know your medical history and looked at that slide on the right, I would say, you'd get a diagnosis of quote unquote polymyositis. That's what that looks like. But that looks identical to inclusion body myositis if you don't see the little inclusions in the muscle, which are those little holes or vacuoles. So many, many people get the erroneous diagnosis of polymyositis because it doesn't look any different under the microscope. That takes the examination and a good medical history to see the difference. Dermatomyositis is on the bottom. That's not for today, but there are certain clinical features, including the way it targets the blood vessels, that is very different from IBM or from any other. So if we're looking at closer at inclusion body myositis, we are looking at, if you wanted to know what kind of cells these are in IBM, these are highly differentiated, what we call CD8 lymphocytes. These are cytotoxic killer T cells that invade these fibers. And then if we are to do a certain stain, so this, you see that it's blue, not red. This is called a gromoric trichrome stain. This is the specific stain that stains those red rim vacuoles, which I gave you the arrow, and those little vacuoles there. I think you can probably see my cursor too, right? So we're looking at these little holes. If we're lucky enough to see those with the right medical history, check the box. That's the diagnosis. Third of the time we see them, and about 2/3 of the time we don't see those vacuoles, those holes. And that's where really our clinical acumen comes into play. I'm actually going to skip this. This is very technical. I'm going to skip that for today. So Team IBM, who's on your team? Physical therapy and occupational therapy. If I've learned one thing, I have learned that I'm not trained as a physical therapist in medical school, and a phenomenally trained team. And I think we need to do a better job about training people throughout the country. This is a real want of mine, and I know it's true of my team here. I am so impressed with the quality of people who see my patients. Many patients will come and say, I've never done that exercise before. And that's because it's tailored for IBM. It's tailored for you. So good quality physical therapy, occupational therapy. And Peter would not mind me saying this, but Peter Frampton was the first person. When I saw him, I noticed that his finger flexors were relatively strong. And it was his guitar playing hand, his non-dominant hand, that was strong. It made me think, it's got to be exercise, and a 50 to 60-year career playing a guitar, certainly daily, is exercise. It dawned on me that those people who use their muscles in a very specific way every day can likely lengthen the time to which they become weak. I mean, we can't stave everything off, and we still develop weakness, but that can be a trajectory that is sort of pushed, and you push that goalpost. So physical therapy, occupational therapy, speech and language, because greater than 50% probably over time will develop some form of swallowing dysfunction. And we want to prevent you from aspirating. So the reason, in addition to enjoying food and not choking on it, so the two things, of course, that would could be fatal events are aspiration, pneumonia, and choking. So knowing how to swallow food, doing maneuvers can have you enjoy meals, but know how to eat them and avoid certain foods that might be of danger to you. You need a rheumatologist and or a neurologist. We can fight over who's better. I mean, it's different for different reasons. Most of us at this center, for example, are cross-trained, and you can see either. In certain parts of the country, only neurologists will see inclusion body myositis. In other places, only rheumatologists see them. And many places both work together, and that is the best way to work. Physical medicine rehab I just talked about, and the patient, it's you. You are the number one person on the team because you have to inform me of what matters to you. What is the IBM FRS? This is a functional rating scale. This is 10 questions about your ability to perform daily activities. How can you walk, dress? How do you handle utensils, pick up small objects? It's answered on a 0 to 4 number basis, and the numbers are added up to give the total score. 40 is the highest, and the lower the score, the more severe the disease is. But many of you who see me and my colleagues know that we do this at every visit, or certainly try to. Then we try to say, and I just saw somebody I hadn't seen in a year, and I said, wow, your IBM FRS is rock solid where it was a year ago. That's very helpful, and it helps anchor the patient who wonders themselves, how am I doing? So it's a nice measure, and I really encourage it. Okay, so here is the study that was done from our group here. Proud of this study. I was in the middle of this sandwich. The people that really heralded this study were Dr. Pinal Fernandez, Dr. Harlan Michelle, who is a neurologist and is a young faculty member who has some part-time work with us over the years, who has an adjunct appointment here. And she and I were very curious. I said to her, I wonder if IBM presents differently in women. So she rolled that into her research question, and her, along with Dr. Pinal Fernandez, Dr. Andy Mammon, who many of you know, Dr. Tom Lloyd, and the rest of my group, were able to contribute patient data on close to 400 patients. 335 met this diagnosis by a standardized classification criteria. And then we compared them to 524 patients with other types of myositis. So this would be the ones I showed you on the slide to start with. So if you compare IBM to all those other inflammatory myopathies, the myositis, you see that IBM is more common in men. So compared to all comers who come to our center, normally we see about 3 to 1 women to men in the myositis field, but IBM has always been about 2 to 1 men to women. And so here, 64% were men. 84% are white, but I thought for the longest time I was never going to see this in a Black individual. And actually, a patient came up to me at our yearly walk, for our charity, and she was a middle-aged Black woman who said to me, I have IBM, and I know you say that you don't see this. I'm like, well, clearly I'm seeing it, right? You're living it. So I think the more we look at this, the more we find, and we just probably are missing this in general in more marginalized populations in healthcare. We notice that we don't see this. So both women and those of color often get misdiagnosed or not diagnosed. And they are older. So the median age of onset was about 59 in IBM comparatively. The average time to diagnosis for IBM is longer. It's on average about 5 years. Many of you on the screen will tell me it took you longer. Fewer patients presented with swallowing difficulty. So interestingly, we saw more swallowing difficulty at the beginning with all the other types of myositis. People say to me, if I don't have swallowing difficulty in the beginning, will I develop it? The answer is that 60% eventually developed some form of dysphagia, but we really do look very carefully for every possible meaning of what swallowing dysfunction is. So yes, over time, people do develop it. I usually say the longer you don't have it, the longer the chances that you will not get it. But there were fewer people at the very first visit that had it when we query them later, okay? So misdiagnosis, over half of patients received an initial diagnosis of something else. You're more likely to be female and younger at the disease, let's just say onset. Finger flexor weakness and rim vacuoles on muscle biopsy, polymyositis more likely to be ANA positive, and or you were told that you had some other myopathy, something that they didn't know, okay? What about women in IBM? This is why we're here. I told you that I lump also in African-American patients because this is true as well. It seems that women and Black patients may have distinct clinical phenotypes, differences in their appearance, and the trajectories over time within IBM, and then fewer than half of the muscle biopsies demonstrated all the things we like to see under the microscope. And so those are the medical terms: this inflammation. Do we have lymphocytes, this type of white blood cell coming in? Are there those holes, those rim vacuoles? And in fact, it's a minority, so you have to be good at knowing what you're seeing rather than waiting for the diagnosis to come on a pathology slide. Black patients had significantly weaker arm abductors, that's the ability to move your arms to the side, hip flexors and knee flexors compared to non-Black patients. Women had stronger finger flexors and knee extensors compared to their male counterparts. So we teach what IBM looks like, and then women defy the rules. We always defy the rules. So this is a problem, right? So I think that we need to be thinking, let's look more carefully at women so that we can see the subtle differences. You may present with finger flexors weakness much later in the disease or not at all. And the other day, just again, I was examining knee extensors and marveling that this woman can keep her knee extensors completely strong, despite the fact that she has every other feature really of inclusion body myositis. But boy, if I taught you only that little subtle differences, which I do when I teach this disease, we may be missing it in women. So you're younger. So generally there are many under the age of 50. So what we notice though, that younger age at the onset is not associated with increased weakness. Several cohorts say the younger you get this, the weaker you are and the weaker you will be. Now, obviously, it goes to without saying that if you live another 60 years with this disease and we don't find anything for it, which is not going to happen, sure, if you get it young and you live to 100, okay, you'll be weaker. But it didn't seem like the trajectory over the same time period said that definitively, the younger you are, the worse it is. We all have experienced patients that do have that story, but that didn't actually hold true for everyone. And then the subgroups may have different responses to therapy, for sure, which can influence the design of future clinical trials, which is what we're all about, right? So women, longer time to diagnosis, more likely to be misdiagnosed. Steroid use was more common in women. We just give women steroids and say maybe it'll work. Women had stronger knee flexors and a tend towards stronger finger flexors, no difference in hip flexors or abduction, that ability to move your arm to the against your away from your body in that strength compared to men. Okay, so there are differences. Let me just in the last few minutes, and I'm sensitive to the time, I want to see if we can get through some chatting before you all have to go to your breakout rooms. So what are the therapies? Well, exercise is really the only treatment recommendation at the moment for patients with IBM. Technically, the people that use off-label therapies, I know. Patients may be fearful, frustrated, feel guilty. All kinds of emotions come around this. It is shown similarly to reduce inflammation, reduces fatigue, increases stamina, builds muscle, even in patients with myositis, all types of myositis. No heavy weights. You want more reps, less weight, minimizing your fall risk, giving you more stability. I cannot say this enough. In my experience, I've often said that if exercise done correctly or in a clinical trial, the FDA would approve it. I had to have my physical therapist remeasure my patient's strength after a good physical therapy program because I didn't believe they got as strong as they did. Prior to me noticing the effect of exercise, I used to say that that could probably prevent further progression. I have seen, and I will say it here, I have seen exercise actually increase strength in IBM. Really, it would be FDA approved. So in the right hands, I can't say it enough. Physical therapy and occupational therapy really do play a large role. What about BFR? This is blood flow restriction therapy. This is controversial. Some people say absolutely does not work. Other people say, I can't imagine it would work any better. I did have, and again, these are very anecdotal evidence. I had one patient in her 80s that she started this, called me and said, I have to come in, you have to measure my strength. I know I'm stronger. And she was. I've equally had people say, I've tried this and it doesn't do a thing for me. So I think that this has not been rigorously examined, but essentially what you're doing is compressing or restricting blood flow with a specific device like this one. And you work out with a tourniquet. And obviously you have to know what you're doing because the tourniquet can't be fully restrictive. It restricts the venous flow, so in the veins, but not the arterial inflow. You do not want to restrict your artery to your extremity or you will lose that limb. So it's got to be done obviously in experienced hands. And then just this is a lot of words to say that there was one small controlled interventional trial that looked at 12 weeks of this, and there were some modest changes. So maybe, right? So preservation of muscle mass, mechanical muscle function with this resistance device can be considered of clinical importance. And maybe it is a countermeasure. Maybe this will reduce disease-related decline in physical function. I think I would say TBD, right? Really to be determined, but I think this is something we all think about. IBM clinical trials have been horrifically disappointing. Every time we get excited, something happens and it does not get approved. We did bigrabrumab, adalimumab, arimoclomol, and sirolimus. Say that 10 times fast, right? So these are all therapies that have been tried. Sirolimus is about to be trialed, hopefully, in a worldwide trial. And that restores what's called autophagy. So this is the way that proteins degrade inappropriately in IBM. We think so. And it inhibits this very specific pathway that's called the mammalian target of rapamycin, or mTOR. So rapamycin is another word for sirolimus, and that is a specific therapy that may target that specific pathway. Some people have used this off-label. I don't necessarily recommend or not recommend it, but it's obviously better to be studied in a clinical setting. Pioglitazone, the second on that list, we did a small trial here at Hopkins, my colleagues Britt Adler and Maima Albeida, myself. The idea was that if we could increase certain molecules like AMP kinase and PGC1 alpha, this helps increase mitochondrial function, because we think that mitochondria in the muscle are also affected. We know they are. And the thought was that it would increase exercise capacity and function. We saw a fairly significant bump in at least one patient, where it was only 9 that completed the trial. And those results are not yet published, but I think what we did notice is that every patient has their own trajectory, and maybe we could personalize medicine for certain patients that would benefit, and certain patients may benefit from something else. So I mentioned sirolimus. The only other thing, this is a lot on a slide. So this is the product that came from the brainchild of Steve Greenberg. Many of you in the IBM world will know his work from Harvard. So Steve is a neurologist who really feels that the T cells, remember I showed you what's called those cytotoxic T cells, they have a certain feature of them. There's a marker called KLRG1 that they hope to use this therapy. It's called ABC008. This is starting to launch in the United States very soon. They studied this therapy in healthy participants, and they saw that it had no apparent safety concerns. They're increasing dose cohorts and enrolling more patients in this. So the idea is to just get rid of these highly differentiated killer T cells and spare everything else, so that you will essentially target the problem in those specific lymphocytes, those blood cells that they believe may be responsible for the destruction of the muscle. If you can go and clear only those out, but not knock out the entire immune system, which of course would lead to infection and other potential safety concerns, this is of interest. And I think this is really sort of what all of us are excited about seeing come to light. So I think that's what I've had for now. And I realize that's a lot in just 35 minutes, but I'm going to stop sharing, and happy to have Nancy or someone else moderate the chat. And I can also look at the chat too, and I'm happy to answer or take questions from there, however you want to do, Nancy.